Female fertility. What does the future hold? This event has been made possible thanks to the support of the Scottish Government, and PET are extremely grateful to them. At PET's most recent event, Advances in Assisted Reproduction, what can we expect? We were given a glimpse into the future of the science of fertility treatment by some amazing researchers based in Edinburgh. And tonight, we're back to the future again, but focusing specifically on female fertility. So we have Professor Siladitya Bhattacharya, Professor Colin Duncan, Professor Richard Anderson, and Dr. Rita Vassena. Batty is Professor of Obstetrics and Gynaecology, and he's head of the School of Medicine, Medical Science and Nutrition at the University of Aberdeen.
Well, thank you so much for inviting me to speak today. We're talking about what the future holds for female fertility, and I'm going to touch on one aspect of that, which is, can we make fertility or conception predictable? And to start that discussion, there have been two discoveries of the 20th century which have encouraged people to believe that there is a reproductive switch that we can turn off and also on at will. In reality, of course, what happens is when couples stop birth control, and I'm drawing your attention to the pink line here, over the next 12 months, if they're exposed to a chance of pregnancy, about 84% will conceive. But of course, time plays a really important role, such that if you look at the blue line, in those who've been attempting to conceive for a year, the chances of conception over the next 12 months falls to just under 50%. And the green line shows what happens in couples who've been trying for 3 years, so a dismal 14%. So clearly, it's the length of trying that plays a part. And of course, this is the basis of our diagnosis of infertility, which is those who don't conceive within 12 months of trying. Something else that has an equally important role is female age. So a woman is much more likely to get pregnant within 12 months if she's younger as compared to an older age group. And as I said, that's how infertility is defined, taking into account one of these two parameters. But in this paper, and you recognize Richard's name here as well, that we wrote a number of years ago, what we argued very strongly was that it's not just the duration that's important, it should be the age as well that should be taken into consideration, such that the higher the age is, the shorter should be the duration before we take action. And of course, that then means that we also consider what happens when we reach that conventional 12 months and make a diagnosis of infertility. At the moment, we do a number of tests, and at the end of it, we come up with various causes of infertility. But there's one group that I'd like to draw your attention to right at the bottom, where we find no cause, which is unexplained, and that accounts for about a third of all cases of people who don't conceive after trying for 12 months. And traditionally, we've looked at a number of factors that are associated with natural pregnancy once a diagnosis of unexplained infertility has been made. And you can see the usual suspects are there, so female age, duration, whether someone's been pregnant before, and something that may seem intuitive, sperm quality. So if we put all that together, I think what I'm arguing is in our approach to fertility in the future, what we should think about is a prognosis-based approach to fertility, because that's what we do at the point of definition, but then we seem to lose track of it. So the underlying principles are subfertility is not sterility, apart from a few exceptions, for example, no sperm or bilateral blocked tubes. So dichotomization of fertility is an oversimplification. But of course, the chance of getting pregnant changes over time both in those couples who start trying for pregnancy after stopping contraception and those with a diagnosis of infertility. And what I'd like to introduce is maybe a concept for the future, which is that of what I would call active family planning, where you start off wanting not to get pregnant and then end up wanting to get pregnant, but in a predictable way. So it is all about ownership of this active decision to get pregnant, but trying to get pregnant on your own first, but making that switch to activating treatment at the appropriate point in time when it is more beneficial to go for a treatment, weighing up risks and benefits, than not going for treatment, but also very crucially, making sure that treatment is delivered before a woman's age is such that the impact of treatment is reduced because of the effect of age. So this is what we're trying to say should happen, which is if you have probability of pregnancy on this line, the y-axis, and duration or time in months on the horizontal line, month on month, we should be able to calculate what a couple or a woman's chance of pregnancy is. We are doing this traditionally now in couples with a diagnosis of infertility, but in the future, the hope is that we can use this to predict chances of conception in those who've just started trying as well. So as a first pass at this, we looked at a population of couples with unexplained infertility, and the question is, can we develop a model or an app that can estimate month-on-month chances, keeping in mind that these chances change over time? And the straight answer is yes, we can. But of course, the caveat is this is only an alpha version. It's a very early stage in terms of our research, and this probably needs to be validated or used effectively in larger populations before we can be absolutely certain of its value. But just before I finish, I just want to draw your attention to two different scenarios. So on the left panel, if you consider couple A, so a couple where the woman is aged 30, the couple have been trying for 12 months and they've never had a pregnancy before. The blue line shows month on month chances of pregnancy leading to a baby from 0 months, the point of diagnosis of unexplained infertility, up to 2 years, 24 months. And you can see that the starting chances are actually quite high, about 30%, but they fall over time. The other lines refer to two common treatments, IUI with stimulation of the ovaries, that's the green line, and IVF, which is the red line, both of which give increased chances. But of course, the accuracy of this isn't perfected yet, so I wouldn't get too excited about the actual values. But the idea is that in the beginning, no treatment gives a reasonable chance, but then ultimately everything comes down towards the end. And of course, just as an example and a comparison, the second panel shows a couple where the woman is much older, 40 years, 24 months of trying and a previous pregnancy. So this is just a proof of concept to show that this can be done, but obviously we need the underlying data to feed into it. And there's an online tool that is available if people want to use it. So just to conclude from that, what I'm arguing for that in the future, there is this growing demand which we'll need to meet for a personalized prognosis-driven approach to fertility. And I'm making this seamless transition from unwanted fertility to wanted fertility, all to be predicted appropriately, such that conception becomes predictable both with and without treatment. This has two benefits. First, this can optimize preparation for a pregnancy so that preconception health can be optimized. Secondly, it helps couples and those treating them decide when and how to treat them. It also has an added benefit that it avoids over-treatment, because often people feel obliged to rush into treatment simply because they have no confidence that waiting will provide any value at all. And if I summarize all that, I would put it under this umbrella of active family planning.
So our next speaker this evening is Colin Duncan, and Colin is Professor of Reproductive Medicine and Science at the University of Edinburgh and at the Medical Research Council's Centre for Reproductive Health. And he's also a consultant gynaecologist at the Royal Infirmary of Edinburgh.
So what I want to do is to talk about female fertility in the future. Well, what I want to do is do something a bit different from some of the other speakers, because I want to talk about some really basic science that we've been doing recently that is years and years away from making a difference, but hopefully it will make a difference. So when I see somebody in the clinic as a couple with fertility issues, what I say to them is that if you put the most fertile couple in Lothian in a room for a month and say try to achieve a pregnancy, at the end of that month, the chances of achieving a pregnancy are somewhere between 1 in 4 and 1 in 5. Now, sometimes something changes that chance, and therefore the chances are not 1 in 4 or 5, it might be 1 in 8 or 1 in 10 or 1 in 20. And what we do at a fertility clinic is we say, is there something changing the chances, and what can we do to make the chances closer to that 1 or 4 or 5? And actually, we're very good at it. We've got a solution. Most fertility treatments that we do have got a success rate of more than that 1 in 4 or 5. So we're doing the right things and we're getting into the right places. And we'll hear about some tweaks that we can do that can perhaps improve things, but there's a problem. And the problem I see every single day that I do a fertility clinic, and I want to highlight the problems that I see when it comes down to female fertility. And the first problem that I see is age-related fertility decline, because I don't have good treatments for age-related fertility decline. And the next problem I see is problems with accessing fertility treatment, which may be very good in the first instance. And I'm not going to talk about age-related fertility decline today. I'm going to focus on accessing fertility treatment. And the big barrier to accessing fertility treatment that I want to talk about is obesity. And I want to talk about obesity as a barrier for fertility treatment in a very specific condition. And that condition is polycystic ovary syndrome. Now, polycystic ovary syndrome is common. One in every 8 women has is on the spectrum of having polycystic ovary syndrome. And why is it important? Well, they have got fertility issues because they don't grow and release eggs regularly, and so come to see us frequently at the fertility clinic. But they've also got issues with their weight. And women with polycystic ovary syndrome are more likely to be overweight or obese. In fact, in the 2 fattest countries in the world, which is the USA and perhaps surprisingly Australia, sort of over 2/3 of women with polycystic ovary syndrome are actually obese. Now, in polycystic ovary syndrome, we're very, very good at restoring fertility. We're very good at making the ovaries work normally. But what we're not good at doing is treating the obesity. And why are women with polycystic ovary syndrome more likely to be obese? Because that obesity is sometimes stopping them getting that fertility treatment, which can be very, very effective. So why are they more likely to be obese? Is it because they eat more, or is it because they exercise less? And the answer is, there's no evidence that women with polycystic ovary syndrome eat more or exercise less. So let's look at the energy balance. You gain weight because the energy balance is swayed. And that's because you either take in too much or you expend too little. So let's look at energy expenditure. And so energy expenditure, let's think about physical activity. And physical activity, burning off calories, is responsible for only about 20% of the energy we expend on a day-to-day basis. 65% of the energy we expend is just by staying alive, okay? Your heart beating, your brain thinking. And then there's another, which is called adaptive energy expenditure, and that's 15%. And that's adaptive energy expenditure, which is classically burning off calories after you've eaten. And that's called postprandial thermogenesis. You burn calories off after eating. After a big feast, you will sometimes feel yourself hot and sweaty, and that's because you're burning off excess calories. And if you look at women with PCOS and compare them to looking at their metabolic rate and their burning off calories after they've eaten, you can see women with PCOS here in the white. They don't do it as well as women without PCOS. And if you look at it, whether it's obese women or even slim women with PCOS, they're only able to burn off 73% of what a control patient without PCOS can burn off. So their energy expenditure is reduced by 25%. So what does that mean? Well, it means there's a deficit, and you have to eat 4% less every single day than anybody else, or exercise 20% more every single day than anybody else to be the same as anybody else. And one of the big questions is, why does that happen and how can we sort it? So our research uses sheep to try to work out why. Sheep, that seems a bit strange. Sheep don't have polycystic ovary syndrome, but actually, if you give a pregnant sheep injections of just slightly higher levels of male type hormone, when they have a lamb, then that lamb grows up. That lamb is slightly different. It's programmed, and it's programmed to have a condition which is very like polycystic ovary syndrome. And interestingly, I've done something to the mother before the lamb's even born, but in adulthood, that sheep ends up being overweight and obese. Okay, you can see here that in adulthood, 24, 30 months, you can see that they've got weight problems. And guess what? It's exactly the same problem that women with PCOS have after eating. You can see that they burn less calories. Here they are, the PCOS sheep are in the red. And if you look at the condition, they do 74% as opposed to 73% women. So they've got this 25% reduction in the ability to burn calories after eating, exactly the same as women with PCOS. So we're able to look at that and work out what the problem is. And we found that the calories are actually burnt off in the fat cells below your skin. And these are the fat cells in green, and they're told to burn off the calories. And they're told to burn off the calories by these red cells here, which are the nerve cells. And these nerve cells are the sympathetic nerve cells controlled by the brain. So what we found was, we found that in our normal sheep, when they eat, there's some insulin signaling, and insulin's the hormone of satiety that increases after eating. That signaling in the brain tells the nerves that there's food, and the nerves go down to the fat cells and burn off the energy, and that maintains the weight. So if you take too much in, you burn off more. In our sheep, what you find is they take in the same amount, but the insulin signaling in the brain is less. So therefore, they're not telling the fat cells to burn off the calories, so they've reduced energy expenditure and some weight gain. So that tells me that maybe we can sort that, and we can maybe sort it if we can raise the insulin in the brain of women with polycystic ovary syndrome. Now that sounds pretty difficult to do, but actually it's not really that difficult to do, because there's something in the brain called the olfactory bulb, and it's where you smell, and it's got little bits of fibers that go into the top of the nose, and it takes up molecules from the nose straight into the brain. So what happens is if we squirt just vaporized insulin up the nose, it'll be taken into the brain. And guess what happened when we did that in our sheep? We gave them intranasal insulin, it increased the insulin signaling in the brain, and they burned off many more calories, and they normalized their energy expenditure afterwards. Now that's very early data, and it's exciting. When we published it, New Scientist thought it was really useful, and they published a thing about it. And so we've gone to the funders to say this might be something that we can use in women, and we've just got some funding to test this in women. So I think that the major thing, as far as I'm concerned, is that one of the things that I think is going to happen in the future for female fertility is perhaps increasing access, particularly to women with PCOS who've got a metabolic reason why they struggle to lose weight. And so if anyone's interested in any more information, there's the NHS website, there's a charity for PCOS, there's a review that I've written about explaining PCOS, and this is another review that just highlights the problems that women with PCOS have.
Next this evening, we have Richard Anderson, and Richard is Professor of Clinical and Reproductive Science and Head of Obstetrics and Gynaecology at the University of Edinburgh. He's also the Deputy Director of the Medical Research Council's Centre for Reproductive Health, and he's a consultant in reproductive medicine at the Royal Infirmary of Edinburgh.
So I want to sort of perhaps not just focus on patients presenting to us with problems getting pregnant in my talk this evening, but perhaps some of these concepts will be really for a more general female fertility regulation concepts. And if we look at what's been going on in terms of female fertility, as in essentially how many women have been having babies over the last few years. These data were just very recently released by the Office of National Statistics, covering England and Wales, of course not Scotland, but it's another story. But what you can see is these changes, and I've just truncated this back at 1970 to make it relatively modern. But what essentially you can see is these declining fertility rates in younger women in their early and later 20s, and increasing proportions of women in their later years, i.e. from the early 30s, later 30s, and indeed into 40s in the green line, all going up. Perhaps actually you'll see right at the edge here, perhaps a little bit of a decline just in the most very recent years. So this has been a big population shift, with younger women essentially controlling their fertility better, and older women wanting to optimize their fertility to carry on having babies later on. And both speakers we've heard already so far today have alluded to the obvious difficulties that's going to arise. But I think that, as Bhatti actually indicated, this raises a lot of issues because essentially at the moment, this changes in population means we're not on a replacement level at the moment. So there's an argument for pro-fertility interventions in the population, although I guess historically other nations have not found those to be terribly useful. But I think it's also important to remember that at the other end of the spectrum, of the something like 640,000 births that happen every year in the UK, about 1 in 3 of them are actually unplanned. And actually, there are something like 200,000 abortions go on every year as well. So there's an awful lot of fertility that is still inadequately controlled. And a lot of that is about access to family planning, but let's just think about as well how we might potentially have novel ways in which we might regulate that as well. So I think that aspect of fertility control is far from answered as yet. So looking at it from a biological perspective, when we think of how the ovary works, we essentially have this concept of a pool of resting, non-growing follicles that progressively start to activate. A lot of them fall away by the wayside by this process called atresia, ultimately getting this 1 egg a month that's released. And our understanding is that these early stages are controlled by local factors, and the later stages are increasingly controlled by the LH and FSH, the two pituitary gonadotrophins that come from the base of the brain. And that's been our understanding of how things work for many years. But I think what we really need to get to grips with this, and I think what science is still struggling with, is really a better understanding of all the different points within this pathway with which we could actually have regulation and therefore influence things, either to enhance fertility, and that might be making this process more efficient in older women, so fewer of the eggs that they're starting to grow up fade away, and they're better at producing more that could be used in IVF to go on and produce eggs, or indeed switching off. And of course, all the contraceptives, the hormonal contraceptives we currently use, act at these later stages rather than these early stages. So we need better understanding of these loci of different checkpoints in follicle development to be able to better regulate it. And as I say, this could be for contraception, it could be for reproductive lifespan. But I think the other thing, of course, within this is this intrinsic tying up in the ovary between the egg and the hormones that really link these processes together, which of course is so different to what happens in men in the testes, where they're rather separate. We can go back a step further and we can think about, well, we can just bypass the whole thing altogether and make artificial eggs. And actually, I think it's important to recognize that that is actually really just around the corner. And there are mice in this world that have been created purely from stem cells. And this is the most recent in a series of fabulous publications from a lab in Japan, where they have progressively refined this over the years. And in this latest iteration, starting from stem cells, induced pluripotent stem cells, not embryonic ones they made to be stem cells, they can produce egg-like cells and then mix them now with artificially generated supporting cells. And that's been a challenge previously because they've had to use ovary cells to do that, but now they can make them as well. And they can mix them together and they can produce the whole follicle architecture artificially from these cells. And they make baby mice from this. And this is just a picture of these mature eggs, very similar to what your IVF embryologists will be looking at down the lab, from a mouse perspective, of course, but a nice mature egg in the surrounding nurturing cells, and, tubes full of them, lots. So that's potentially not so very far away. Sorry, I'm just not. So, but if we want to stick with the ovary, how are we going to actually regulate things? Well, one of the key aspects of this is this finite population of non-growing follicles within the ovary that we potentially could regulate, either slow down its activation or speed it up temporarily to try and enhance fertility where there's a diminished supply. And we're aware of these different pathways that are needed to regulate this, to maintain this pathway, potentially to regulate this activation and control it, and also to eliminate ones as well. And we're more and more aware of the different biochemical pathways that underpin this. And with that goes the opportunity to make interventions. So a lot of the field around this actually has been built on damage to the ovaries, and that's particularly with the advent of the very rapidly growing field of fertility preservation, looking at chemotherapy effects on the ovary and how these might be prevented. And just to give you one little example of a vast now literature on this is this study from some colleagues in Melbourne. And what they did is they identified this key gene, PUMA, which is one of these BCL2 elimination pathway proteins effectively. And they removed this gene from these mice. And they showed here that compared to normal mice, where if you treat them with these two different chemotherapies, you drastically remove the number of follicles within the ovary. In these modified mice, you can see the ovary was completely protected from both these chemotherapeutics. Now that's a drastic insult, but these mice, this is a normal pathway, and this pathway didn't evolve to protect mice against cyclophosphamide. It evolved to regulate the pathway physiologically. And so if we understand this pathway, then potentially it's tractable by drugs, and we can then intervene to affect it. So that's just one, that's right at the beginning. What about at the other end? And when we heard a couple of weeks ago, a lovely talk by Adele Marston looking at what really makes a quality oocyte. And I'm sure Rita, the next speaker, is going to go on and speak about that in more detail. And Adele highlighted these cohesin rings that hold the chromosomes together that are so important for preventing abnormal embryos. And you can see there are different pathways within that we know are absolutely critical. And if those go wrong, you get abnormal embryos. So these are potentially factors that can be regulated as well. But the other aspect, and I think it's interesting how it links quality and quantity of eggs actually, is some growing literature on the genes that underpin how old you are when you go through the menopause, i.e. when you run out of eggs. And a fabulous paper published just earlier this year now identifies no less than 290 genes that are linked to age and menopause, i.e. the number of eggs that you have and how quickly you use them up. And what's really striking about their findings is how many of them are linked to DNA repair. And so if you're better at repairing DNA damage, your eggs will last longer, is the message from that. So that's a really interesting finding, and one that will be potentially tractable for the future of how to affect these things. But is it all about then, if you do that, if you had a drug that could do that, would it just give you more not very good eggs? Would that just not be very effective? Well, actually, perhaps not. So if we go back to this Puma experiment from Melbourne again, you can see this is now them looking at the number and the age at which their animals were able to carry on successfully having offspring. So when they looked at how old they were when they had their first litter, no difference. The drugs didn't completely sterilize them, so it's not affected. But when they looked at how old they were when they effectively ran out of fertile eggs, you could see that the drugs damaged the normal ovaries in the animals, but actually in these animals, they were again completely protected. So this wasn't just more eggs, it was better eggs for longer and live births as a result of that. So how translatable might all this sort of thing be to humans? Well, you know, as Sarah said, this is all very early stages, and we're talking about Colin's work with the intranasal stuff. This is going back a step further to animal models. And perhaps just to sort of highlight that there is still an awful lot we don't understand about human fertility. I'm just going to end with some unpublished data that we've recently generated, looking at Scottish databases of fertility, or putting together databases for fertility after cancer, and looking at women who've had breast cancer, who actually quite infrequently, only about 8 or 9% of them go on to have a baby after treatment. And we thought that those who had been treated would perhaps have a shorter time in which they would be able to go on and have children if their ovaries had been almost completely depleted of eggs. But actually we found they weren't. They were able to go on having pregnancies and successful pregnancies and live births for as long as age-matched healthy women in the general population. And indeed, the time, the interval between their diagnosis and their last successful pregnancy was actually slightly longer than the control population. Now, of course, there's an awful lot of issues of choice and things like that in this, but it just, I think, highlights that our perceptions of what we think goes on within the ovary can be, you know, are on shaky ground. And there's an awful lot going on about how this is all regulated that we still don't understand. And if I can just try and pull this together, just if it's not overly presumptuous, just to sort of bring up this fifth freedom that Sir Dougal Baird from Aberdeen brought up, which is, as I say, just over 50 years ago. And he highlighted the need to escape from the tyranny of excess fertility. And as I showed right at the very beginning of this talk, we haven't completely conquered that, but perhaps it is time to update it, to think about the freedom to control our fertility, both positively as well as keeping it under control, and to protect it, and indeed, where necessary, to enhance it. And I hope I've given you some thoughts as to how that might happen in the future. Thank you.
So I'm going to move on now to our final speaker this evening. He is Dr. Rita Vassena. Rita is the Scientific Director of the Eugin Group, and she's Associate Professor of Translational Medicine at the University of Barcelona and Academic Director at the Barcelona School of Management.
Okay, so let me start by, of course, thanking you, Sarah, and the Progress Educational Trust for this beautiful invitation. I'm very happy to be here, and I'm really intrigued by the topic of this evening because it gives me the opportunity to speak about something that it's really very dear to me, actually, and that shows how much IVF has and the way that we practice assisted reproduction is a reflection and is tied to our society. So the first point that I would like to make is how much IVF has changed in the last 10 to 15 years, or perhaps a little bit more. We have gone from medical treatment. We had, of course, the main goal to try to help a couple or a woman to have a child, to what I think is now a societal instrument that works through the practice of high-tech medicine, basically. Why I say this? Because I noticed that current IVF, especially IVF, is predicated around a string of selections, a progressive string of selection. So we do aim to select for the best oocyte, to select for the best sperm, and then select the best embryos. And we have developed and are still developing several tools over the years that overall are going all in the same direction, which is to identify that one embryo, the one transfer that will give us the best possible shot, so to speak, at the baby. And of course, on the one hand, this is very understandable because we know we know and we see every day what the peculiarity of IVF treatment are, and the heartbreak that too often actually is part of the fertility journey. But also, and also we know that IVF patients are very risk averse, and in fact, for instance, we know that pregnancies from assisted reproduction technologies, they end in an elective C-section twice as much that age-matched spontaneous pregnancies. So this is understood. However, I think that the reason that is at the base of this focus on selection, the initial motive for this attitude that we have, it can be found mainly in the progressive shift in our treatment towards an older patient population. Because basically, in the clinic, we are faced with the opposing forces. We have to select because on the one hand, we see progressively more fragile gametes as especially women, but also men arrive at the clinic at an older age. But also, as we have heard, still we don't have very clear how we can improve and modulate the quality of these gametes. And so there's nothing left for us than to select as much as we can. However, the selection and this way of treating patients, they have sort of side effects that come into play when we try to push for the most effective transfer or the fastest possible pregnancy. So let me tell you what are these effects that I see. First of all, there is the truth that is often, unfortunately, unspoken, that no amount of selection, no matter how incredible the technology, no amount of selection can improve the substance of what we already have in the ovary, in the dish, in the sample. So what selection does is basically dividing what's already there into more likely to give a pregnancy and a live birth, or less likely, or from good and bad, or better to worse. And so the selection of oocyte and embryo from PGTA, artificial intelligence, time lapse, PGTP, which is now the new kid on the block, they're all way of ranking. They're all way of placing the oocyte or embryos in one order, from supposed best to supposed worst, and then trying to pick the one at the top of the list and see if we can have this baby. Then there is a second point, which is no technology, no action, nothing that we do in the lab or in the clinic, it's neutral, nothing. So every additional manipulation, taking the oocyte or the embryo out of the incubators, freezing, thawing, prodding, taking a biopsy, looking for a long time, or leaving the oocyte for a long time under the microscope while we are selecting the best sperm by IMSI, for instance, all this is not neutral. And of course, we know that some of these effects are not so dramatic, but they are there. For instance, if we think about embryo freezing, is extremely efficient. In fact, we know that we lose after thawing no more than 2-3% of all embryos, which is another way of saying that 97% of the time, freezing and thawing of an embryo is effectively very successful. But we can also say, in other words, that we lose one embryo every 40, more or less. And if we translate this into patients that are affected, we are affecting about one couple or one patient or one woman every 10 to 15. And so, these people will have their chances affected by what we do through selection. And then there is another obvious consequence of this way of practicing assisted reproduction, because the more you select, the more thing you do, the more expensive the treatment becomes. And which leads me to the fourth point, which is something as more expensive it becomes, this piling up of selection at the population level has the effect of basically providing at best the same number of babies faster to a smaller portion of people, while leaving a substantial amount of patients at the door of treatment. So from this consideration, I would like to move on to look at this from a societal point of view, so to speak. So I was just last Sunday, I went walking up the mountain because here in Barcelona, we don't have bad weather. And I was with a colleague of mine, which is a medical director of one of our clinics. And at one point we were discussing work because we don't know how to relax. And he told me, you know, I used to treat primary infertility, but now all I do is to treat older people. And of course, we know, and we say it, and we heard this so many times, that in part, this is due to an overall lack of reproductive awareness and reproductive education, more so among men, but also among women, and unfortunately also among reproductive professionals. And in fact, us and others have shown that if you ask gynecologists in this case, if IVF, for instance, can take away some of the effect of aging, half they will tell you that yes, of course, this will work, or they would overestimate the end of reproductive life in women. Nevertheless, we should not forget that there are way more powerful forces that are at play in reproductive decision. So I will make a few comments about Spain, because Spain is particularly striking in this regard, but I would like you will see that I will also make points about overall the European area. And I think what I'm going to say can be translated to most resources-rich countries. So in Spain, for instance, about 90% of all employment contracts that are made new are on a temporary basis. They're not permanent position. And sometimes they're renewed year after year, but they're never permanent, or very rarely they're permanent. And in Spain, like in many countries, if you don't have a permanent contract, you cannot get a loan from the bank, you cannot buy a house. And sometimes, depending on what kind of contract, how short is this contract, you cannot even rent an apartment to live in. And apart from the contract type, in the last 10 years, for instance, the monthly income of reproductive age people had in fact went down in Spain, and is now below 1,000 euros per month. And amazingly, the amount of proportion of this income that goes into just paying rent, just being able to afford a roof over your head, went from about 28 to about 40%. And if we look at the part of the country where most of the people live and most of the work opportunities are, which are the area around Barcelona and the metropolitan area of Madrid, which together they have about a quarter of the population of the country, you see that up to 55% of a reproductive age person's salary goes just into, having a house. So it is not a surprise, looking at this number, that more than 80% of the people that are up to 30-year-old, so at the best moment, biologically speaking, to have children, they live with their parents. And like I said, this data are particularly striking for Mediterranean countries. You see there, Italy, Greece, Slovakia, Spain, Portugal. But even in the UK, about 70% of adults below 30 now live at home. And as another data point that I would like to give you, about 1 in 4 young people in Europe are at risk of poverty. And if we take out of this those that do not live with their parents, with their family of origin, 2 out of 3 are at risk of poverty. And then, because this is always happens, if we go and look at women specifically, there was this very interesting report that looked at 30 years of data from Denmark, and basically they concluded that having children is very penalizing to women in several ways. So they found that most of what remains of gender inequality in earnings is due to the fact that women have children. And also they found that when a woman has a child, there is a gap in earnings that in the long run reaches about 20%. And this is due to a mixture of participating less in the workforce, reducing the amount of hours that you can work, and also the fact that you're paid less just because you have a child. And amazingly, these penalties, these earning penalties that are due to having children, they are transmitted through generation from parents to daughters only. So it is not really a surprise that the age at first birth in the European Union, or in general in the European area, they are so high. Our society, in fact, they are actively work against parenthood, especially young parenthood. So I would like to finish here with a few commentary and what I would call perhaps a call to arms. So I think I'm really convinced that the future of female fertility in countries like ours, in resources-rich countries, is predicated just a little on our ability to decrease barrier to access for treatment of the kind that we have heard tonight. But it would really depend a lot on our push as professionals for a society where people are placed in the social, financial, and professional position so that they can have the children that they wish to, when they wish to, rather than when they can. And I think we need, as ART specialists, to be very, very vocal and advocate for policies and laws and regulation, because what we are really advocating for, it would be, in essence, preventive medicine. And this is really something that we need to do because it's part of our call and it's part of our duty.
What do you think about the use of oral anti-diabetic drugs in the treatment of PCOS?
Okay, so when it comes down to sort of fertility in women with PCOS, there are better drugs available to make the ovaries work better than oral anti-diabetic agents. So for instance, the oral ovulation induction drugs, the use of gonadotrophins for ovulation induction, have better success rates than the oral anti-diabetic agents. Now, when it comes down to the more metabolic things, then that might be slightly different. Now, when it comes down to the oral anti-diabetic level, there's some new exciting things going on with the glucagon-like peptides, which are experimental at the moment. The glitazones are a little bit too toxic, so we're really talking about metformin as the drug that's available at the moment. And in my experience, metformin has 3 potential benefits. It sometimes increases the energy levels of the woman. It will make the ovaries work a little bit better, so the cyclical control will be a little bit better, and thus slightly increasing fertility. It doesn't make you lose weight, but if you're on metformin and you're losing weight significantly, then a lot of patients will say that it helps them reach a lower level before they hit the brick wall. So I think that as far as that's concerned, there are really good things about metformin, but if I give it to 3 women, one of them would get these benefits, one of them would see no difference at all, and another one would stop because of side effects. And we don't have any biomarkers that are able to tell us which woman is going to be which.
Thanks for that, Colin. I'm guessing the others don't want to come in. No, I can.
Can I chip
Yes,
in?
Richard.
So Colin, there are drugs becoming available that actually are started to become actually quite effective at helping people lose weight. And of course, it's mostly been in diabetes, but it may well be generally applicable to the population as a whole, and specifically, of course, for women with polycystic ovary syndrome. So it's interesting just to speculate that if these drugs do become more widely available, are we going to see a much more of a medicalization of weight? And of course, that does have an impact on fertility. It's perhaps a bit of a red herring for our major focus today. But it's again another medicalization of part of normal of the broader human experience. And I wonder whether your thoughts are about the much more widespread pharmacological approaches that we might see in the future for that.
Yeah, I mean, I think it's very clearly that there's a massive big lifestyle issue with regards to weight. And what I was focusing primarily on was the deficit that means that women with PCOS are more likely to have weight problems. But I do think that the glucagon-like peptides are having some sort of very nice effects with regards to sort of treatment of diabetes and perhaps weight loss and diabetes. And there are additional strategies which are coming online. Now, we know that weight loss and diabetes is phenomenally good for the improvement of diabetes and the improvement of life span and the well-being. And so therefore, I do think that there will be a medicalization when there is a medical problem. Now, whether there's going to be medicalization of diet or exercise-induced obesity without an underlying metabolic issue is something which is, so the ethicists will be continuing to debate from now on, I would imagine.
So I think we'll stick on the theme of obesity with this question from an anonymous attendee. Do you think the obesity epidemic is a factor affecting fertility? And perhaps we'll go to Richard first on that one, and then others can chip in.
Thanks. Yeah, I think that is the case. It is, and I think it's a factor in men as well as in women, actually. And I think, you know, the title of our symposium tonight was very much on female fertility, but I think that undoubtedly the average male weight is increasing as well, and there is evidence that that actually decreases sperm quality as much as effects on egg quality. So there is actually a wealth of evidence about effects of obesity on female fertility. And a lot of it relates to its interactions in IVF, because that's such an easily sort of controllable experiment effectively in terms of how you get good data, but it seems to be applicable to the general population as well. So yeah, absolutely.
If I could come in there as well, I think that the answer is, of course, yes. Specifically looking at polycystic ovary syndrome, if you were to scan sort of all the women of reproductive age, 1 in 5 of them would have polycystic ovaries on the scan, but only sort of 1 in 8 will actually have polycystic ovary syndrome. Only a third of those women will have polycystic ovary syndrome. But if you gain weight, women will move from just having polycystic ovaries into polycystic ovary syndrome. So you'll often see somebody whose periods are absolutely normal, they'll feel absolutely normal, they'll behave normally, then they'll gain weight, and then their periods will become irregular. They'll be diagnosed with polycystic ovary syndrome, which is a condition you're born with, but it manifests when weight increases more.
That's really interesting. I hadn't quite made that connection. Rita, I didn't know whether you wanted to comment on the situation in Spain. What's the obesity problem like there?
It's definitely growing, but I don't think it's the biggest problem that we are facing, actually. I see some of the comments actually also in the question that are really comments, not questions, and there is a recognized difficulties in having children before the end of our reproductive lifespan. That is considered, I think, the biggest issue right now.
And I think we can perhaps just clear up something that's it just popped up in chat for me. What we're talking about here when we're talking about obesity, what BMI are we referring to? Someone wants to know. We're talking about over 30 or over 35. I don't know who wants to go first. Perhaps Colin first.
Okay, so when it comes down to sort of obesity, the standard definition would be a BMI of 30, but anyone with a BMI that's over 30 is obese. Now, there's different BMI limits for different treatments that are available, but the crucial thing about it is there's not a specific BMI where issues could be manifest. We do know that the fat under the skin metabolizes these hormones, and obviously the more fat under the skin there is, or the more fat there is in the body, the more problems there are. And that's perhaps not entirely dependent on BMI.
Thanks, Colin. So our next question is for you. Your talk raised a lot of questions for people. So this is from Jo Delange. So she says, what was given to the pregnant sheep to make the lambs grow up and develop PCOS? Does this mean that in humans, PCOS could have epigenetic causes from before the patient was born or while they're in utero?
Okay, so the first answer, what we do is we give some male hormone testosterone injections to the sheep during the mid stages of pregnancy. Is that clinically relevant? So therefore, does that mean that it perhaps is the case in women? Well, women with PCOS have higher levels of male tech hormone in pregnancy, we know that. But the crucial thing about it is that if you look at experiments of nature, such as a woman developing a testosterone secreting tumor during pregnancy and look at their female offspring, then they have got some of the features of PCOS. If you look at markers of male hormone exposure in utero, such as finger lengths and cord testosterone levels, inner genital distance, etc., what you can see is that women who have got a diagnosis of PCOS or children from women with PCOS seem to have slightly higher evidence of increased testosterone in utero. So I think that it probably does happen. Now, whether or not that's a way of inheriting from without genes, so in more of an epigenetic way, it's difficult to know because the placenta tries to protect the fetus from testosterone. But I think that the fact that just changing one slight little thing with the mother's pregnancy, making a huge difference to an adult offspring, is something which is fascinating. And the fact that it's so similar to PCOS means that we are probably learning something about the etiology and the development of PCOS. So I think the short answer is, I do think there is PCOS before birth, and there probably is a role of androgens. Now, how much of that is environmental, how much of it has got little genetic elements to it, but I think the pathways are probably similar, actually, to be honest.
That's interesting to think about, and the exposure to testosterone. So the next question is for Batty, from someone who's chosen to be anonymous. How much can we depend on AMH to predict fertility?
The model that I spoke about did not have AMH within it, but actually the question's very timely because we've just completed a paper using American IVF data that does show that in women undergoing IVF, AMH levels do predict the chances of live birth. So the straight answer is it is predictive, but I can't quote an exact figure for exactly how predictive it is, because it's predictive amongst a number of different elements, some of which I've mentioned, such as age and type of fertility.
So yes, certainly you can.
Yeah, so I think that it was important there that Batty answered his question by talking about IVF data rather than by natural conception. And there the data are actually fairly clear, as far as we have the data at the moment, that that AMH does not predict natural fertility. Because what AMH is doing is telling you how many follicles are growing in your ovary at one point, but actually the chances of whether you're going to fall pregnant over the next few months are whether you're ovulating or not and releasing that one egg. And you can release one egg a month whether your ovaries are full of eggs or are running low. So that AMH does not really protect natural fertility over the course of a year or so.
And a related question has just popped up. So do AMH tests work accurately if you have PCOS? So who wants to go with that one first?
Well, I think the answer is that one of the things about PCOS is we're thinking about the diagnostic criteria for PCOS. That involves increased androgens, it involves irregular periods, and it involves polycystic ovaries in a scan. But you have to do a scan to be able to tell whether somebody has polycystic ovaries. And it's very clear that women with PCOS have increased AMH levels because they have a lot of little small follicles within the ovaries. And therefore, the question is that can you actually use AMH, a high AMH, to predict PCOS? You certainly can use it to predict an over response in IVF. Can you use it to predict AMH? And there's a lot of research going on to say that can that be used as a PCOS predictor? So I think that definitely there's increased AMH in PCOS.
Anybody else?
Certainly, it does also, it does predict, as you say, Colin, an over response in IVF, and that's the sort of perhaps the most established and clearest use of AMH in identifying women who are going to over-respond in AMH and potentially become unwell, and therefore you can modify your treatment strategy. So I guess the answer, the key answer there is yes, it does work if you're about to have an IVF cycle.
Thanks. So I'm going to sort of go off on that. So I sort of often come across people, you know, going for private AMH tests, thinking this is going to be some sort of, you know, predictor for their whole fertility future. What would the panel say to those women in relation to that? Perhaps Richard or Batty, do one of you want to go first?
Well, if I start the conversation off, I think we've got to view tests in context. Tests are used for very specific questions, and AMH is a test for fertility now, in the next 6 months, forever, is not a useful test. And I don't think there are reliable data suggesting that it can be used as a test to predict future fertility. So I think there's enough data to that effect. What it can predict is how women respond to hormonal stimulation of their ovaries as a part of IVF treatment. So I think it depends on what the question is. And I think your question was very clear. Does it predict fertility as a whole? And the answer is no. But also many of the things we've discussed, or I've discussed earlier in my presentation, suggests that fertility as a whole depends on a number of things, not just one person at one point in time.
My view, Sarah, is the fact that AMH can give an idea about the ovarian reserve, number of eggs in the ovary, but doesn't tell you anything about egg quality. And age tells you an awful lot more about egg quality. So you'd much rather be a 24-year-old with a lowish AMH than a 42-year-old with a high AMH.
Thanks. I think the question that is essentially being asked when people have these tests, Sarah, is you know, it may be, am I, you know, what's my chance of getting pregnant, and whereupon you're better off doing something else. But often it's a question of how long have I got? And that's the sort of perhaps the intrinsic question going on subconsciously, if not overly consciously. And there again, the data are really fairly modest on how valuable AMH is. You might think it makes sense that something that tells you how many eggs you've got growing in your ovaries will tell you how long your ovaries are going to last before you go through the menopause. But the data we have thus far on how good it is at predicting menopause is really not very impressive. It's pretty shaky on that, unless it's absolutely imminent. And even then, it's actually much better at telling you you're not just going through a menopause than telling you you are going through a menopause.
Great. Now I have a sort of slightly related question from Emily Engel. I'll go to Batty first with this one. Is there a predictive tool for women trying to get pregnant without a male partner? Because this would be very helpful in choosing treatments.
Well, the straight answer to that is at the moment, no, because we are at the mercy of the data that we have at our disposal. But there's no reason that with active participation from women in that constituency, as it were, we could not have a tool predicting chances of conception. But obviously we'll need a different form of data. And I think I kind of hinted at that because, to be absolutely honest, the data we have is from an infertility clinic. So it refers to people who've had a diagnosis of infertility. But what we would really like, and that's the futuristic element in it, is to use data from couples or individuals who are trying for pregnancy. And I think for that, we really have to go down the route of crowdsourcing data, but that technically could allow us to develop the appropriate prediction tools.
Richard or Colin or Rita, do you want to come in on that? No. I can see lots of comments about Rita's presentation in strong agreement about the problem for women in terms of financial security, job security, and that you know, women are in terrible employment conditions. And I don't know the data here, but I can't imagine it will be strikingly different. So I think you've really touched on something there with the audience. But I think, Rita, you know, big question, you know, how do we change this? You know, what can we do?
Yeah.
You know, as individuals, really, I think.
So I think we should start by recognizing that this is really a problem that is not, we're not just the fixers here, but we are part of a possible solution. So I would start by saying that one thing that we could start doing is to stop thinking of this as an issue of lack of knowledge and lack of awareness, because this takes away the focus on broader forces that are acting, that they are shaping the way, well, I'm thinking about Europe, but we can think in the same way in other countries that are shaping basically the demographic aspects of our societies, and have been at play for the last 50, 60 years. So this is not something that we can change, of course, overnight, but just starting to acknowledge that there are these very powerful movements that are at play. And then I think we should be very vocal, like today, with the media, you know, with in public, in social media. I think we should make this part of the job of reproductive professionals. It really, if we can push so much that some of these conditioning factors are a little less, you know, a little weaker. It's the same thing as saying, you know, we have saved somehow a number of people to become infertile and then come to us. So to me, really, is part of the job of a clinician, is preventive medicine in our case, applied to the social structure. But really, I think we should be as vocal as possible and as organized as possible.
Yes, I think.
Can I chip in, Sarah?
Certainly, Richard.
Thank you, Rita. I think, you know, absolutely agree with what you said, and I think it's so important to give that perspective of, you know, it's often the case when you talk to infertility specialists that they talk about what they know about, and it's fantastic to recognize that there's so much more. And you highlighted this, the challenges of education, and how this might be essentially a red herring and going down the wrong path. And I don't know if any of you saw an interview on the news a week or so ago about this, about fertility education, an interview with one of our London colleagues, and she was absolutely roasted, both live and on Twitter thereafter, for saying that this was absolutely not appropriate. Women do not know about this. It's all the social structures that make it so difficult for women to have children when they want to have children, from unaffordable housing and childcare and everything else. It's not that they don't know.
And if I can just add to that, and the potential hesitancy of the male partner,
oh, absolutely.
or the difficulty in finding a male,
as well,
or the difficulty in finding a male partner.
Yeah, and all this is actually being shown abundantly to be worse the more educated the woman is.
Yes. Well, we won't go down what we could do to solve that, because that would, you know, certainly talk about being roasted on Twitter. That would be, you know, hung, drawn and quartered. So I'm going to move on to the next question. Alison Motluck, who's joining us from Canada. Dr. Bhattacharya mentioned an online tool. What's the URL? She wants to know. Can it be posted? If not, then Bhatti, please send it to me, because I didn't make a note of it in the time.
Thank you, Sarah. But
and actually, I can pass it on.
I can show that if you can give me a couple of minutes, because it's in the slide.
Yep.
There we are. And if I click on it, that takes us to the web page.
The thing is, we can still only see your slide.
Yeah.
We can't, yeah, because you're sharing your screen, so we can only see your PowerPoint presentation. So perhaps the quickest way to deal with this is for you to send it me, and I can send it on to Alison tomorrow.
Sure,
and anybody else who wants it, we'll put it, once we've got it from you, then we can put it on Twitter as well, on our other social media channels. So okay. Yeah. Great, thank you for that. And we've also had some requests for some of Colin's links as well. So Colin will send those to me, and we'll put those out tomorrow, and we'll think about how we can share them as widely as possible. Okay, so another question from Chami Lambamba. Can we improve the selection tools to avoid all these side effects that you have mentioned? So I think I'll go to Rita first with that, because you sort of were talking about this sort of cumulative effect, perhaps, of all these different selection tools.
No, I don't think we can. Of course, every technique can be perfected a little bit more, but if we think the perfect example to me is the one that I made of embryo vitrification is extremely successful. It's almost always successful. So these alterations are small. They at the population level maybe they don't affect, but they add up. Oh, 2% here of a biopsy that is not readable, 2% there of an embryo that needs to be discarded because did not survive thawing, and a little bit not really even measurable decrease in reproductive potential if you leave an oocyte a little too long outside of the incubator. All these add up, and of course very strict quality control and very strict protocols and good good practice limit this, but there is nothing that we do that is neutral. There's nothing absolutely. So an amount of damage is built in what we do. It's necessary.
So would you advocate going to sort of very basic fertility treatment, sort of cutting out a lot of these?
Well, I would advocate for doing what is necessary and not more.
Yeah. Okay. Right. Then the question that I was going to ask next was for Richard from Emily Walshy, or Walsh with it. If the majority of genes of interest for preserving oocyte quality are contained in the DNA repair apoptosis, there be an implication for an increasing cancer if these molecules were to be therapeutically targeted?
Yeah, thanks, Emily. Excellent question. Actually, I think it's absolutely something that would need to be fully investigated, but actually it's even the other way around. So one particular gene that comes out in these screens, or two, to be honest, are the BRCA genes, BRCA1 and BRCA2. And these are, as I'm sure you know, cancer predisposition genes, and they are DNA repair enzymes. And so that then puts it the other way around, that inhibiting those would reduce, and therefore optimizing DNA repair would actually reduce the chance of cancer as mediated through that particular pathway. So it's certainly important, it's absolutely essential, but I think there's perhaps reasons to think that it might actually improve rather than actually make it worse.
Can I ask you a follow-up to that? Is it possible?
Sure.
So is there, I was when I was listening to you, I was thinking more or less along the same line, and I was thinking about some of these population research that show that women that have later menopause, they tend to have a lower risk of several health effects from cardiovascular, but also I think certain type of cancer. You think there's a link there?
Yeah, so actually, in this paper that I was referring to that was published this summer that identified all this, they actually did identify that looking at their genes, what they would predict is actually a lower risk of particularly diabetic related cardiovascular disease from, associated with this. And a later menopause, but of course there are other cancers that would be increased with that. Of course, notably breast cancer, not through a genetic reason, but just through more prolonged estrogen exposure. So there's always going to be a sort of a caveat and a double-edged sword probably with these things. But I think I agree with your point.
Great. Now we're very near the end of time, but there is just one question left, so I'm going to ask it, and potentially we'll run over slightly, so apologies for that. But the final question is about regulating infertility drugs to prevent a Mandy Allwood situation occurring. And I'm trying racking my brains, the name seems very familiar, I can't quite remember the scenario. But fertility drugs given to women are not required to be regulated by the HFEA, this person says, which is surely ridiculous and can lead to terrible consequences for women. So I don't know who wants to come in on that first.
Well, can I
Richard?
comment? I'm sure Rita might want to as well, because I think worse than the drugs not being regulated at all from the fertility perspective. Of course, the drugs are very regulated by drug regulatory authorities, but what is not regulated are the media that embryos are grown in, and because they are devices, they are not drugs. And so the companies who produce embryo media that all these babies start off their first few days of life in are secrets, and they're not rigorously tested. And we know from scientific studies that have been done that if you compare different embryo media, actually you can see differences in the outcomes and in for example, the birth weights of babies that are born from different media. And so I think that is a real oversight from the regulatory process at the moment.
Yes, and I think there's perhaps potentially some moves afoot to have it regulated as a culture media as a regulatory in the regulatory framework under devices. I heard something, or was some gossip about that recently. Does anyone else want to come in? Someone's put me out of my misery about who Mandy Allwood is, and it's come back to me. She was dubbed in the media Octomum. So yes.
So I mean, I think that one of the interesting things, Sarah, is the fact that all fertility drugs which are used are Goldilocks drugs. Too little isn't very good, and too much isn't very good at all. And therefore, the crucial element is monitoring, and that's responsibility of clinicians. And it's as far as the HFEA is concerned, then that tends to be a reporting basis and with a framework. And I think that the crucial thing, as far as we can do as clinicians, is to make sure that our ovulation induction strategies are properly monitored and controlled. But one of the issues that we often see is women buying drugs over the internet and using them in an unregulated way, and I think that's perhaps more of an issue.